Hi, welcome to my ECG video blog. I'm Ken Grauer, and this is my 6th ECG video blog, which is part 3 and the final installment of my clinical approach video series on cardiac arrhythmias. My goal is to complete this overview of arrhythmia management from a primary care perspective with a look at the SVT rhythms. Please be aware of the webpage I've made with supplementary material relating to cardiac arrhythmias. And here is my email address. Feel free to write with comments, questions, and feedback. On to today's topic. Having covered monitoring methods, assessment of the patient, and premature beats in part 1, and then ventricular rhythms plus bradycardia with sick sinus syndrome in part 2, what remains as the topic for this final part 3 video are the rapid supraventricular rhythms. We begin with the definition. By the term supraventricular, we are referring to rhythms for which the impulse originates from at or above the AV node. Practically speaking, this limits the site of impulse formation to the SA node, to somewhere within the atria, or from the AV node itself, or essentially anywhere at or above this dotted blue line. As a result, the QRS complex should be narrow when the rhythm is supraventricular, as it is seen to be here. The easiest way to define narrow is that the QRS complex is not more than half a large box, that is, not more than 0.10 second, which is clearly the case here. Exceptions to this rule, when the QRS complex may be more than 0.10 seconds in duration for a supraventricular rhythm, as is seen here, include pre-existing bundle branch block and aberrant conduction. Note that the QRS complex in this lead 2 rhythm strip is wide, more than half a large box in duration, but the rhythm is sinus. The QRS widening seen here is the result of pre-existing bundle branch block. That said, if in all 12 leads on an ECG the QRS complex is narrow, this virtually excludes the possibility that the rhythm is VT. On the other hand, consider this long lead V1 rhythm strip. Despite a seemingly narrow QRS complex, this is not SVT. Why not? The answer is apparent if we look at the simultaneously recorded 12-lead tracing. Here's lead V1 with a seemingly narrow QRS complex, but look at each of the other 11 leads. Is there any doubt that the rhythm is VT? Moral of the story, 12 leads are better than 1. You'd never know this rhythm is VT if the only lead you had looked at was lead V1. So what's our agenda for the rest of this part 3 video? Our goal is to review some of the SVT rhythms commonly seen in primary care with focus on ECG recognition, applying the P's, Q's, and 3R approach, and then highlighting key points in clinical management. What's this? Let's say that the patient is hemodynamically stable. The good news is that since the patient is hemodynamically stable, we do not have to be certain of the rhythm diagnosis at the time we initiate treatment. The best approach is the easiest one. Simply describe what you see. We do this by use of the P's, Q's, 3R approach, which should be our mantra for rhythm interpretation. Regardless of the arrhythmia, once we ensure hemodynamic stability, we approach rhythm diagnosis in the same manner by using the system. So, look for P waves. If present, is the rhythm sinus? Q's. Is the QRS complex wide or narrow? And the 3 R's. What is the rate? Is the rhythm regular? And if P waves are present, are P waves related to the QRS complex? It doesn't matter in which sequence we look for the P's, Q's, and 3 R's, as long as we always assess each of these 5 parameters for every rhythm we encounter. So let's apply the P's, Q's, 3R approach to this rhythm. The rhythm is regular. The rate is approximately 150 per minute. We know this because of the rule of 300. To figure out the rate, divide 300 by the number of boxes in the R to R interval. Find a QRS complex that begins or ends on a heavy line. We can see that the R to R interval for this rhythm is 2 large boxes. So the rate is 300 divided by 2, or about 150 per minute. The QRS complex is narrow, that is clearly not more than half a large box, and we don't see any P waves, so there is no P wave to be related. What have you described? You've described a regular SVT rhythm at 150 per minute with no clear P waves. The reasons for describing what you see, rather than jumping to a specific rhythm diagnosis, are that this systematic approach organizes your thinking and defines the diagnostic possibilities. For practical purposes, think of 3 entities whenever you see a regular SVT rhythm without definite P waves. These are 1. Sinus tachycardia, 2. Atrial flutter, and 3. PSVT, or paroxysmal supraventricular tachycardia. These 3 entities make up 90 to 95% of what you will see in a primary care practice when you encounter a regular SVT without definite P waves. The good news is that even if you are uncertain about what this regular SVT rhythm is, initial management is similar. Ensure that the patient is stable, and they almost always will be for SVT rhythms. Allowing for slight differences depending on whether the SVT rhythm occurs in or out of the hospital, a vagal maneuver will often be considered first. For those regular SVT rhythms occurring in the hospital, adenosine is often the first drug given. Alternatively, either IV diltiazem or an IV beta blocker may be used, usually with comparable success. The main difference with outpatient therapy is that the drugs are given orally. But regardless of where the SVT rhythm occurs, attention should be given to finding and fixing potential precipitating factors, which may prove especially important for preventing recurrence. Let's hone in on management of some specific types of SVT. Let's say that the rhythm is PSVT. The patient is hemodynamically stable. So how do we know that the rhythm shown below is PSVT? The answer relates to the process we suggested earlier. Namely, once you ensure that the patient is hemodynamically stable, the next step is to simply describe the rhythm by the P's, Q's, 3R approach. That is, the rhythm below is fast, it appears to be regular, the QRS complex looks narrow, that is not more than half a large box in duration, and sinus P waves are not clearly seen. We can't tell if the upright deflection highlighted by the red arrow is a P wave, T wave, or some combination of the two, which means that for practical purposes, we have a regular SVT rhythm without clear evidence of sinus P waves. The key for distinguishing between sinus tachycardia, atrial flutter, and PSVT in this example lies with the heart rate, which we estimate to be about 180 per minute. We estimate the rate by the every other beat method. The R to R interval for every other beat is just over 3 large boxes. Therefore, half the rate is a little bit less than 100 per minute, or about 90 per minute. Since half the rate is 90 per minute, the actual rate is 90 times 2, which is about 180 per minute. Sinus tachycardia in a non-exercising adult does not usually exceed 160 to 170 per minute. Untreated atrial flutter most often conducts with a 2-to-1 AV ratio, which means that the ventricular rate for atrial flutter is most often between 140 to 160 per minute. This leaves us with PSVT as the probable diagnosis for the SVT rhythm seen here. PSVT is a reentry arrhythmia. This accounts for the newer, and probably better, name for this rhythm, which is AVNRT, or AV nodal reentry tachycardia. So what do we mean by reentry? As implied in its name, AVNRT involves reentry contained within the AV node. The electrical impulse is caught in a cycle that circulates around the AV node. Each time the impulse comes around, it generates an impulse that is conducted to the ventricles as a QRS complex, and each time the impulse comes back, it conducts retrograde to the atria, which we can sometimes see as a subtle notching in the terminal portion of the QRS complex during the tachycardia. The key to treatment is to appreciate this perpetual cycle. Anything we do to interrupt the cycle may break the arrhythmia. Potential interventions include vagal maneuvers, AV nodal blocking drugs such as adenosine, diltiazem, or a beta blocker, and even anxiety reduction because the autonomic nervous system may affect conduction properties within the reentry circuit. So what happens with the vagal maneuver when the rhythm is PSVT? The answer is either nothing, or there may be fairly abrupt conversion of PSVT to sinus rhythm, signaling that the transient increase in vagal tone produced by the vagal maneuver has successfully interrupted the reentry cycle. All you have to do is briefly interrupt the cycle to break the arrhythmia. How then do we treat PSVT? Let's assume that the patient is hemodynamically stable, as they almost always will be with PSVT. We'll start with a few definitions. For practical purposes, PSVT is a synonym for AVNRT, or AV nodal reentry tachycardia. Beyond the core, you may come across the term AVRT, without the N, which is AV reentry tachycardia. With atrial ventricular reentry tachycardia, AVRT, the patient has WPW with participation of an AP or accessory pathway within the reentry circuit. That said, for practical purposes, since 95% or more of the AVRT rhythms you will see conduct down the AV node first and then back up the accessory pathway, the QRS complex will be narrow during the tachycardia. No delta wave will be seen, and initial treatment considerations are virtually identical as when the reentry circuit is entirely contained within the AV node. As a result, we need not initially concern ourselves about whether the rhythm is AVNRT or AVRT. In either case, initial management is really similar to initial management of the stable patient with a regular SVT of uncertain etiology. Consider a vagal maneuver, if appropriate. If the patient is being seen in the emergency department or within the hospital, consider adenosine versus outpatient management, in which case oral AV nodal blocking agents are used. Note these common themes that we have consistently discussed in each segment of this video series regarding long-term arrhythmia management. We need to determine if the arrhythmia is benign. PSVT usually is. Are there precipitating factors you can fix, or other contributing factors such as heart failure, ischemia, electrolyte disturbance, or hypoxemia? Does the patient get better by controlling these fixable factors, or does the arrhythmia continue to occur, in which case you might consider medication, perhaps a trial of an intermittent beta blocker for a benign recurrent arrhythmia. In the case of PSVT, if symptomatic episodes continue despite these interventions, realize that referral to an EP cardiologist is an option, since ablation of the reentry circuit could be curative. That said, much of the time, avoidance of precipitating factors and targeted use of medication will be all that is needed to control the arrhythmia. Let's say that the rhythm is this. Once again, the patient is hemodynamically stable, which means that once again we begin by assessing the P's, Q's, and 3 R's. The rhythm is rapid and regular. The R to R interval is 2 large boxes in duration, so the rate is 150 per minute. The QRS looks to be narrow, and we don't think sinus P waves are present. The PR interval of this positive deflection looks too short to conduct, and if this negative deflection is a P wave, then the rhythm isn't sinus because the P wave isn't positive in lead 2. Therefore, our impression is that There is a regular SVT rhythm at 150 per minute, possibly with atrial activity, but without sinus P waves, so that our differential diagnosis for practical purposes once again consists of three entities: sinus tachycardia, PSVT, and atrial flutter. At this point, we could try a vagal maneuver or simply treat the patient for SVT. For illustrative purposes, I wanted to show the effect that a vagal maneuver had on this patient, large arrow, which you can see reduced the number of impulses conducted through the AV node. It should now be apparent that these negative impulses that are regularly occurring at a rate of 300 per minute are flutter waves. Use of calipers is invaluable for detection of atrial flutter. We look for a typical sawtooth pattern where each tooth in the saw is precisely regular. That said, atrial flutter can be subtle. It is easily overlooked, and about 15% of cases are atypical and will not necessarily have a recognizable sawtooth. But this case is illustrative for how to recognize typical atrial flutter. Beyond the core. Atypical AFlutter may not be distinguishable on ECG from atrial tachycardia. Clinically, this doesn't matter because initial management is the same, and such patients should probably be referred to your EP cardiologist for long-term management, regardless of whether the rhythm is persistent flutter or atrial tach. Let's follow through with this case, in which the rhythm is AFlutter with 2-to-1 AV conduction, which is the most common presenting AV conduction ratio for untreated atrial flutter. The rate seen here is 150 per minute, but our patient is stable. For practical purposes, initial management of AFlutter is similar to initial management of atrial fibrillation. That is, we use similar drugs, have the same potential option of electrical cardioversion, and the same potential long-term option of possible cure with ablation therapy. However, there are some important differences. First, AFib is much more common than AFlutter in the general population. It will often be much easier with medication to control the ventricular response to fast AFib compared to fast AFlutter. That said, flutter is much easier to cardiovert and lower energies are needed because flutter is a more organized rhythm than AFib. While both AFib and AFlutter may be cured, or at least greatly improved, by referral for ablation, cure rates for typical AFlutter attain 90% or more, whereas success with ablation is less with AFib. Perhaps the best candidates for successful ablation of AFib are those with intermittent episodes, since it is easiest to target the site for ablation in such patients. Finally, both AFib and AFlutter patients should receive long-term anticoagulation, though the risk of clot formation is probably greater for AFib. New rhythm. This patient is hemodynamically stable. Using the P's, Q's, 3R approach, we see that the rhythm is irregularly irregular, but it is not AFib. This is the reason why. There are P waves. As shown within the red circles, there are lots of P waves, which all look different. Completing our analysis, the QRS complex looks narrow. So what do we have? The answer is MAT, or multifocal atrial tachycardia. In our experience, MAT is the second most commonly misdiagnosed arrhythmia. AFlutter is by far the most commonly missed rhythm. The best way not to miss MAT is to always maintain a high index of suspicion for this diagnosis whenever you see an irregular rhythm in one of two settings. The most common clinical setting for MAT is with severe pulmonary disease. To help recall the other setting in which MAT is seen, I think of MAT as an exit arrhythmia, in that it is often seen in real sick ICU patients with multi-system disease. The importance of recognizing MAT and distinguishing it from the much more commonly occurring irregular rhythm, which is AFib, is that treatment of these two entities is different, which is why I always like to obtain a 12-lead ECG when unsure about any arrhythmia. P waves might not be evident if all you are using is a single monitoring lead. The treatment of MAT is simple. Treat the underlying cause. The rhythm will often resolve if you improve the patient's pulmonary status or correct their underlying sepsis, electrolyte disorder, acidosis, anemia, and address other multisystem problems. This leads us to the last cardiac rhythm that we'll discuss. Here's the case. This lead 2 rhythm strip was obtained from a 60 to 70-year-old adult who presents to the office with this rhythm. The patient is hemodynamically stable. Using the P's, Q's, 3R approach, we note that this rhythm is irregularly irregular with a narrow QRS and no P waves. This defines the rhythm as atrial fibrillation. What's unusual about this example of AFib? The answer is the slow rate. New onset AFib most often presents with a rapid ventricular response. So, initial presentation of AFib with a slow ventricular response, that is with an average rate below 60 to 70 per minute, should suggest the same clinical considerations as new onset bradycardia in an older patient. Namely, rule out medication effect, recent ischemia or infarction, and hypothyroidism, and if none of these are operative, the patient probably has sick sinus syndrome. P.S. Don't forget to consider the possibility of sleep apnea whenever you see bradycardia with arrhythmias consistent with sick sinus syndrome. Treatment of sleep apnea may cure the bradycardia in such patients. So this is how our last rhythm much more commonly presents, as AFib with a rapid ventricular response. Our first consideration is the same as it is with any new arrhythmia. Determine if the patient is hemodynamically stable. They most often will be when the rhythm is AFib. That's not to say that the patient with new onset rapid AFib will not be sick, but rather to emphasize that in the vast majority of cases, emergency cardioversion right then on the spot will rarely be needed. Exceptions may exist when new onset rapid AFib is associated with hypotension from a large acute MI, or if the patient's condition for any reason suddenly deteriorates, in which case go ahead with emergency cardioversion. But in most situations, the patient with new AFib will not be hemodynamically unstable, and you will have time to initiate medical treatment. In such cases, I find it easiest to summarize the main treatment considerations for stable new onset AFib into 5 priorities. 1. Find the cause of AFib. 2. If possible, fix this cause. Then, slow the rate, convert the rhythm, and prevent stroke. Taking this one step further, I suggest considering these 5 priorities in this sequence, since if you can find and fix the precipitating cause or causes of AFib, you'll often automatically slow the rate, convert the rhythm, and prevent thromboembolism. Let's look at these priorities in a little more detail. What are the 3 most common causes of AFib? No, hyperthyroidism is not one of the most common causes, though it is always important to rule this out because treatment of AFib due to thyroid disease is very different. The 3 most common causes of new AFib are heart failure, coronary disease from ischemia or recent infarction, and long-standing hypertension. The mechanism by which long-standing hypertension may lead to AFib is that long-standing hypertension results in concentric LVH with diastolic dysfunction. That is, the left ventricle becomes thicker and stiffer, which makes it more difficult for the left atrium to empty. This leads to an increase in left atrial pressure with associated left atrial dilatation that predisposes to atrial fibrillation. Because older hypertensive patients with diastolic dysfunction become more and more dependent on the atrial kick for up to 40% of their cardiac output, these patients are prone to decompensate when the atrial kick is lost by sudden development of new onset AFib. There are many other potential causes of new AFib, some of which I list here. The one that I want to spend a minute on is lone AFib, which is generally defined as AFib and nothing else. No underlying structural heart disease, not even hypertension. The reason I use 60 or so years of age as my cutoff is that risk of stroke goes up dramatically in patients older than 60. The beauty of this definition is that it defines lone AFib as a lower risk group, which is an extremely helpful concept when contemplating decisions about long-term anticoagulation, as I'll discuss momentarily. What then is the workup for new onset AFib? For the most part, the workup is intuitive. One orders the standard lab tests as for any significant acute medical disorder, such as hematocrit, electrolytes, renal function, with the rest of the workup directed primarily at determining the cause of new AFib onset. The 12-lead ECG confirms AFib. It rules out MAT, and it also provides insight on the likelihood of ischemia or recent infarction in a patient who may or may not be having chest pain. Realize that hypo as well as hyperthyroidism may be the cause. An echo is essential. This does not mean that a patient with recurrent AFib needs to get an echo each time AFib recurs, but at least initially, an echo is key to the workup. The echo may provide insight to the etiology of AFib, be it from hypertension with progressive diastolic dysfunction or valvular heart disease. It provides insight to the risk for stroke, depending on the presence of clot and LV size and function, with transesophageal echo being far superior to transthoracic 2D echo for assessing stroke risk. And finally, it may also provide insight to the likelihood that you'll be able to maintain sinus rhythm, which may be extremely helpful when trying to decide if the patient is a candidate for a long-term antiarrhythmic agent. Finally, oxygen saturation, chest X-ray, etc. are intuitive tests that will usually be ordered. The workup should help you determine if the patient with new AFib needs to be admitted to the hospital, as not all patients with new AFib need to be treated in the hospital. Let's look at the next priority, slowing the rate of new onset AFib. The important point is that you will usually be able to slow the rate with medical therapy. This may happen naturally if you can find and fix the cause, but even if you are unable to correct the precipitating cause, medication will usually work. In the U.S., IV diltiazem, bolus and drip appears to be the most commonly selected first choice. Alternatively, a beta blocker could be used, especially in situations such as the postoperative state in which increased sympathetic activity is likely to be a contributing cause of the AFib. While best to avoid simultaneous IV infusion of both diltiazem and an IV beta blocker, because this may cause excessive rate slowing, addition of titrated doses of an oral beta blocker to IV diltiazem is usually quite safe and may synergistically slow the rate. Digoxin is used much less often than in the past, though for those providers comfortable with its use, digoxin may provide synergistic rate slowing in an occasional patient with heart failure worsened by new onset AFib. Finally, amiodarone has both rate slowing and rhythm conversion effect when used IV in a controlled hospital setting. Note, other than amiodarone, drugs that slow the rate generally do not per se convert the rhythm, although spontaneous conversion to sinus rhythm often occurs as the patient's medical condition improves. Conversion of new onset AFib is the next priority. The important point to remember is that if you do absolutely nothing, no treatment at all, that approximately half of all patients with a new episode of AFib will be in sinus rhythm within 24 hours. There is just a high incidence of spontaneous conversion to sinus rhythm, even without any specific treatment. A greater percentage of patients will convert to sinus rhythm if you are able to find and fix whatever it was that precipitated the episode of AFib, be this worsening of heart failure, transient hypoxemia, low potassium or magnesium levels, a surge in sympathetic tone from psychologic stress or overexertion, or consumption of a few too many alcoholic drinks. As a result, this is one strategy for treatment. there is really no urgency for immediately converting most patients with a new episode of AFib. At least there is no rush to convert them over the first few hours. So one strategy for the hemodynamically stable patient is to slow the rate and fix whatever predisposing factors you can. Ensure adequate anticoagulation, closely follow the patient to be sure they are doing okay, and then reassess after 24 to 48 hours. Many patients will spontaneously convert to sinus rhythm during this time. For those who don't, you can now, at this time, individualize your assessment and determine if this patient is a candidate for attempted cardioversion. This brings up a number of issues regarding cardioversion, with my use of the term cardioversion including both attempts at medical, that is using drugs, and electrical, that is using synchronized shock delivery, cardioversion. Key point: not all patients are candidates for medical or electrical cardioversion. For those who are candidates, realize that the best chance you'll ever have to convert them to sinus rhythm, and more importantly to maintain them in sinus rhythm, is with the very first episode of AFib, before anatomic and physiologic remodeling has occurred. AFib begets AFib. The longer you are in AFib, the more likely you are to stay in AFib or revert back to AFib if you are temporarily converted out of this rhythm. Being in AFib for a few extra hours probably doesn't make that much of a difference, but persistence over a period of weeks to months clearly makes subsequent attempts at cardioversion and maintenance of sinus rhythm more difficult. The next key point is that anticoagulation of rate-controlled AFib is a perfectly acceptable option. The days of trying to convert and maintain all patients in sinus rhythm are over. The drugs just don't maintain sinus rhythm for that many patients. Even if drugs initially work to convert AFib to sinus rhythm, the longer out that you follow such patients over ensuing months, the greater the chance that AFib will recur. Unappreciated point. Simple things like maintaining a healthy lifestyle, good diet, no smoking, minimal alcohol, appropriate exercise, adequate sleep, and stress reduction are surprisingly effective for reducing the recurrence rate of AFib, with this pearl coming from nationally known electrophysiologist John Mandrola, who says the need for his services to ablate AFib would be dramatically reduced if people simply adapted healthy lifestyle changes. The reality is that most episodes of AFib are asymptomatic. We see the patients who have symptoms. Holter monitoring studies have taught us that up to 90% or more of all episodes in patients with intermittent AFib are asymptomatic, which means that we cannot rely on the patient's history to tell us if a drug is keeping that patient out of AFib. Which brings us to this controversial point. Should the patient with a new episode of AFib be cardioverted in the emergency department? More and more emergency physicians are doing this on more and more patients with new AFib. The issue to me is not whether ED physicians are capable of AFib cardioversion in the ED, because they certainly are. So I think electrical cardioversion is appropriate for some patients. That said, while the risk of stroke does not seem to increase from ED cardioversion, cardioversion is a procedure and there is potential for other adverse effect. My point, given the high spontaneous conversion rate and the likelihood of AFib recurrence after successful cardioversion, is why do it, except perhaps for the occasional patient with infrequent recurrence who comes into the ED saying, "I know the risks, doc, just go ahead and zap me because it usually works, and then my AFib usually doesn't come back for many months." Final issue regarding cardioversion. When should the primary care clinician refer the patient with AFib? The point I want to make is that when management of AFib becomes problematic, consider the option of referral, with optimal referral in this case being to the cardiology specialist in taking care of atrial fibrillation. Optimal referral is to an EP, that is, electrophysiologist, since the largest segment of patients that EP cardiologists see are those with chronic AFib. Some of these patients may be candidates for potentially curative ablation of their arrhythmia, especially those who go in and out of AFib with frequent recurrence. Be aware that the EP cardiologist may be able to help when your approach is not optimally working. Which leads us to the final issue, preventing stroke. Fact: long-term anticoagulation reduces the risk of stroke by up to 70% in long-term studies. The big question is who to anticoagulate. A number of systems have been proposed for assessing stroke risk and determining who to anticoagulate, the most widely followed of which is the CHAD score, now up to CHADS VASC2. I've put a copy of CHADS VASC2 in the lecture notes that you can refer to later. For now, given time constraints, I thought I'd simplify the topic by presenting an easy-to-remember approach that worked well for me. I found it easiest to begin by addressing who not to anticoagulate. Obviously, don't anticoagulate long-term AFib patients with contraindications to anticoagulation, which might include noncompliance, abnormal baseline coagulation profile, or elderly patients with an excessively high fall risk. There is also questionable benefit, if any, from anticoagulating patients with true lone AFib. As I emphasized earlier, patients with lone AFib make up a much lower risk group. While there is always potential for benefit from anticoagulating any patient with chronic AFib, the potential for harm from bleeding complications probably balances out any potential for benefit in this lower risk group. So, as for a 0 score on the CHADS VASC2 scale, it is reasonable to use aspirin alone for patients with true lone AFib. That said, there is no perfect answer. So my preference was always to present the pros and cons directly to the patient when making my recommendation, encouraging them to help me decide the best approach for them. Which leads me to my last slide, deciding between Coumadin versus novel oral anticoagulant drugs. There is good news. The good news is that there is now an alternative to Coumadin. The new oral anticoagulant drugs are easier to take than Coumadin. There are fewer drug-drug interactions, and there is no need for INR monitoring. The less good news is that there is no free lunch. Of prime importance in the decision of whether to go with tried and true Coumadin versus newer oral anticoagulant drugs is who will be paying. The newer drugs cost up to 50 times more. Reversal of anticoagulation if adverse bleeding occurs is difficult, if not impossible, with the newer drugs. Given the newness of these drugs, there may also be adverse effects that we've not yet discovered. The main benefit of the newer oral anticoagulant drugs is that the risk of intracranial hemorrhage may be reduced by up to 50%, which sounds good if referring to relative numbers, which is the pitch put forth by drug companies with interest in selling the drug. But given some 60,000+ patients enrolled in the randomized clinical trials, the absolute reduction in ICH bleeds was less than 1%. Crunching the numbers, a patient has a 99.4% chance of not having ICH on a new anticoagulant drug versus a 98.8% chance of not having intracranial hemorrhage on Coumadin. Said another way, you'd have to treat 150 patients with a newer anticoagulant for one patient to benefit. Absolute risk reduction for stroke, if a newer anticoagulant is taken instead of Coumadin, is about the same as the reduction in ICH risk, with bottom line that clinical outcome will be the same for 99% of patients regardless of whether they take a newer anticoagulant versus Coumadin. So, once again, talk to the patient. Have them help you decide what is best for them. Is cost a factor? But whatever your patient decides, just realize that for 99% of patients treated, the newer drugs are neither safer nor more effective. That's it. Thank you for viewing this third and final video on clinical management of cardiac arrhythmias from a primary care perspective. I welcome your feedback and suggestions. This is Ken Grauer saying goodbye for now.